Alright, so now let's talk about finally an abnormalities that we may see on an EKG. Mumtaz. The first abnormalities we can finally assess for is the hypertrophy of the ventricles, whether the right or the left one, as well as assessing for atrial enlargement, like the left atrial enlargement, or يسموها P atrial in mitral stenosis, or right atrial enlargement, يسموها P pulmonale, which may be seen in tricuspid stenosis, ممتاز, or right ventricular failure, ممتاز. So we're going to assess for these abnormalities. The enlargement of the atrium, the right and the left one, P atrial, P pulmonale, another name. And we're going to assess for hypertrophy of the ventricles, the right, as well as more commonly the left ventricle, ممتاز, especially left ventricle hypertrophy seen in aortic stenosis, seen in hypertrophic obstructive cardiomyopathy, hypertrophic obstructive cardiomyopathy, genetic disease in young people who might have a cardiac arrest while they're doing exercise, and right ventricular hypertrophy secondary to any pulmonary hypertension, So we're going to look at these abnormalities. So before we continue, let's revise the steps of our search pattern. First, on an EKG, look at the heart rate, assess the PR interval, the QRS interval, and the QT interval from previous video, and then assess for the axis of the P wave, the QRS, and the QT interval, which is between -30 to +90 degrees, looking at lead 1 and AVF. Alright, now we're going to look at all the way to step number 7. We have a total of 9 steps, by the way. We have step number 7. Why did we go immediately to step number 7? 2 reasons. 1, it's easy. 2, it will implement what you've learned so far in the previous 2 videos. All that you've learned in the previous 2 videos, it can be implemented in the criteria for ventricular hypertrophy and atrial enlargement. Mumtaz? Mumtaz. Now, again, let's remind you one more time before we continue. Let's remind you about the cardiac axis, the heart in a horizontal plane, where you have the leads placed in different positions, right? Lead 1 and AVF especially. Mumtaz? Let's remind you one more time as well about the precordial leads, which view the heart from a vertical position. And you have from them a total of 6 precordial leads attached on your chest. And this one, V1, as we said, is joined with AVR as a right-sided lead, V2 to V4 interior leads, and V5 and V6 lateral leads, right? Now, there's one thing I want you to keep in mind. What I've mentioned about the cardiac axis for the limb leads is the same idea with the precordial leads. It's just that these are viewing the heart from vertical, and this one is viewing the heart from a horizontal plane. But the idea is the same, meaning that V1, since it's placed on the right, Mumtaz, is going to view practically the right side of the heart, Mumtaz, the right atrium and the right ventricle. And as you know, the vector is the same, regardless, inferior laterally towards the left. What I want you to keep in mind is that a lot of the leads, like in V1 will specifically show its QRS complex. These are all QRS complex of V1, V2, V3, V4, and V5, V6. These are all QRS complexes. If you notice, there's a key difference in the QRS complex of V1 and the QRS complex of, let's say, V5. What's the difference? The difference is the amplitude of the R wave and the S wave. You can see we have a deeper S wave than the R wave in V1. In V5, it's the opposite. X, Y, because the vector going from the SA node, when it goes inferior lateral, is going to go away, Mumtaz, or it's going to come towards it very briefly, but in general, it's going to come towards the V1, more than likely very briefly, but most of the time it will basically be away from it. So basically the vector here going inferior laterally, it will produce a deeper S wave, a negative deflection, much more so than an R wave. Mumtaz? However, since we have V5, which is practically placed on the lateral side of the chest, or on the which is viewing the lateral side of the heart, since the vector is coming towards it, it's going to have a greater R wave than an S wave. This R wave represents ventricular depolarization. The S wave represents the remaining parts of the ventricles that's being depolarized, and the ones that's practically going left and right. Most of the case going away from it slightly. So in V5, we will have a deeper R wave in amplitude compared to an S wave. While in V1, the R wave will be smaller than the S wave, or the S wave will be deeper than the R wave in amplitude. Mumtaz? This is normal. And by the way, if you notice throughout, you can see that the R wave, as we go from V1 to now V2 going interiorly, V1, V2, V3, V4, V5, and V6, if you notice, the R wave, as we go from as we go through each precordial lead from right to left, the R wave is getting bigger and bigger and bigger and bigger and a little bit smaller in V6 compared to V5. That's normal. But in general, you can see what is known as the R wave progression. In the R wave progression in just the precordial leads, the R wave, as we go through each subsequent precordial lead, is getting bigger in amplitude, because these leads are now starting to view the heart. Instead of the right side, they view it in interior and laterally. And they're now having this vector coming towards it. So now the R wave will be much bigger as compared to the S wave. Mumtaz? This is very important to know when we come to this video and upcoming videos. Mumtaz? Because this R wave progression, this is normal. But in some cases, this can be affected. You might say the opposite. You might say this R wave being bigger than the S wave, and this one the opposite. And we'll see an example of it in this video. Okay? So that's a quick little explanation about really the cardiac axis of the precordial leads, similar to the cardiac axis revolving around the limb leads. Okay? Let's give it a check. Now, let's talk about hypertrophy of the ventricles as well as enlargement of the atrium. Okay? Now, let us start with enlargement of the atrium. P atrial or P pulmonale. Mumtaz? We have our lovely two chambers. Now, when I want to assess whether there is atrial enlargement, right or left, I will look at two leads. I need to look at two leads, one that is sensitive to atrial depolarization, and another one that is specific, or very prone to atrial depolarization. I want leads that will tell me something about the activity, the electrical activity that's going on in the atrium, from the SC node and AV node, the right and the left atrium, right? I need to look at a lead that is sensitive to this atrial depolarization, and a lead that is specific to the activity or to the electrical activity of the atrium, which is V1. Mumtaz? Now, let's start with lead 2. Now, lead 2, placed at 60 degrees of angle of orientation, will view the heart inferiorly, right? And more specifically, it will view the vector inferiorlaterally. Lead 2 will give me a pretty good idea of what is going on with the atrium regarding electrical activity. Mumtaz? So that's the beauty about lead 2. It is like what you say, sensitive. You know, it's very prone to atrial depolarization. And as you know, a P wave, since it's going inferiorlaterally, and this vector coming towards the positive electrode of lead 2, you know that the P wave will be upward deflection. That is normal. That means it's between 0 or between minus 30, like let's say 0 to plus 90 degrees in general, right? It's within that range. It's a normal P wave. Now, axis. Now, the thing about the P wave, it's normal, and it shouldn't be enlarged, طبعاً. It should just be a very brief amplitude before we proceed with the QRS, right? That's regarding lead 2. Now, what about V1? V1 is specific. V1 can tell me very specifically activity in the right atrium and activity that's going on in the left atrium separately. So I don't have to see one single wave. I don't have to cut it in half. I can see them separately. That's from V1. In which in V1, it produces for me a P wave, which is biphasic. A biphasic P wave. That means that this P wave shows an upward deflection. This upward deflection reflects right atrial enlargement. Right atrial depolarization, if you remember from previous videos. while negative deflection of this P wave represents left atrial depolarization. ممتاز. So if you remember, if you can imagine it, this vector coming towards this side, the right atrium being depolarized will show a positive deflection, and since it's going towards the left atrium away from the V1, it will show a negative deflection. So a positive deflection first, a negative deflection down, combination produces a biphasic wave. But how? Very simply. Here we have a positive electrode of V1 and a negative electrode of V1. And here we have the wave of depolarization of what's going on in the SA node. You see what's going on here is that you can imagine this is V1, all right? And practically what's going on here is that when there's this vector, when this vector is going inferolaterally, when it's going inferolaterally, it's going to hit the V1 halfway. So it's going to go through. It's going to hit the V1 halfway through. So basically, the right atrium will be depolarized, and it's going to hit V1 since it's close to it, since it's basically in front of it halfway through. Then the remaining half, as this vector, as this depolarization goes towards the left atrium, now it's starting to go away. It's now going away from the positive electrode. So at the same time, following a positive deflection, there will be a negative deflection. The wave of depolarization that was going inferolaterally, it was going to go to the right atrium. That was going to cause a positive deflection, going towards the positive electrode. Once it reaches the left atrium, it's now going, the wave of depolarization is now going away from the positive electrode of V1, thus causing a negative deflection. So the idea is that with a biphasic wave, in order for a biphasic wave to be produced, the wave of depolarization has to be perpendicular to the lead. It has to be perpendicular to it, like in such a scenario where I'm V1, I'm V1, here comes a wave of depolarization towards me, positive deflection, positive electrode, positive deflection. It's going away from me, negative deflection. So I'm going to produce a biphasic wave, positive deflection, negative deflection combination of a P wave. ممتاز? That's it. And this will give me activity of the right atrium first, and then the left atrium second. Now in normal scenarios, there shouldn't be any increase in the duration and the amplitude. ممتاز? The duration and the amplitude shouldn't be bigger than they have to be, because if they're in any way affected in their duration, which is the square, remember the squares? Horizontally, in their duration, or if they're affected in their amplitude vertically, then there's suspicion, since P wave represents atrial depolarization, there's suspicion if there's any effect in the duration and the amplitude that there might be atrial enlargement. The question is it the right side or is it the left side? Now, we have a criteria. Now here's the criteria for the right atrial enlargement. Let's say we have an enlargement of the right atrium due to tricuspid stenosis. Well, what is my criteria to diagnose for right atrial enlargement? Well, I will look at lead 2 and I will look at V1. ممتاز? I will look at lead 2. If I see that the amplitude of the P wave exceeds 3 small squares, meaning if I count the number of small squares of amplitude, 1 millimeter, 2 millimeter, 3 millimeter, if I see this P wave is within the third small square, 3 millimeter or above, then this confirms for me more than likely right atrial enlargement. ممتاز? Why is there an increase in amplitude? Because the right atrium is enlarged. That means there's more depolarization. ممتاز? And additionally, since we have an enlarged right atrium, normally the left atrium, just like its brother, left ventricle, both of these chambers are bigger than the right side. So if you have an enlargement here, it might cause axis deviation. It might cause the QRS to be deviated towards the right. So in right atrial enlargement, you might find a right axis deviation. So lead 1, negative deflection, AVF, positive deflection, kissing each other, the right for one another. To confirm, you look at lead 2 as well, where it also shows a negative deflection from previous video. So 2 criteria to diagnose for right atrial enlargement, P pulmonale. You look for right axis deviation, and you also assess the amplitude of the P wave. You count the number of squares. If you see 3 millimeter, 1 millimeter, 1 millimeter, 1 millimeter for each small square, then the amplitude of the P wave has been increased, right atrial enlargement. That is all in lead 2. In V1, the same concept. Mumtaz, it is literally the same concept. Here we have the right atrial enlargement in V1. Notice how the amplitude of the first portion of the P wave is much larger than the portion of the than the terminal portion of the P wave. You can see how the amplitude of this biphasic P wave, the positive deflection, its amplitude is much greater than the amplitude of the left atrial depolarization. So that's another sign of confirming right atrial enlargement, where the right atrial depolarization is much greater than compared to the left side. Mumtaz? You can see the difference between the two in both of these scenarios, and as well as these two. Mumtaz? Now, a question. The amplitude is affected. There is an axis deviation. Nawaf, what about duration? Is the duration of the P wave also affected? Actually, no. The duration is the same. Why? Because, yes, there might be right atrial enlargement, but at the end of the day, it's going through the normal pathway. The right atrium is depolarized first, although much bigger, and eventually, since it's depolarized first, it will go to the left atrium to be depolarized second. So there is going to be no difference in duration. The duration is the same as it is. It's normal because the right atrium is being depolarized first. Mumtaz? However, if we now have left atrial enlargement, now the duration of the P wave will be affected. Mumtaz? Because it's going to be depolarized toward this area a lot more longer. Mumtaz? So now the criteria, like we said, if you see the amplitude of P wave, it's affected, as well as right axis deviation, this is P pulmonale, right atrial enlargement. You look at lead 2, you look at V1. Lead 2 here, V1 over here. And look at the comparison between the normal and the abnormal. Mumtaz? Now, what about left atrial enlargement? Left atrial enlargement, the same concept. Literally, the difference is two things. First of all, in left atrial enlargement, there's no axis deviation. There's none. Why? Because the left atrium and left ventricle, they're the dominant ones. So you're not going to rely on left axis deviation. There's no axis deviation. It's normal in case of left atrial enlargement. However, when we look at lead 2, compare this one, we can see two things. Number one, the amplitude is increased. More than one small square. Mumtaz? So more than 1 millimeter. That is for the amplitude. And then when we assess the duration in this one as well as this one, we can see that the duration of the P wave has also been increased. How can I confirm whether there's this increased duration? If there is more than one small square. If you have a duration of practically more than 0.04 seconds, يعني more than one small square, then in that case, that can confirm left atrial enlargement. So, to confirm left atrial enlargement, you can see increase of duration, more than 0.4 seconds, more than one small square, as well as increase in amplitude, more than one small square, right? More than 1 millimeter, right? So you see this in lead 2, and you see this in V1. You can see how it's much bigger in amplitude and the duration as well, compared to this one. Mumtaz? This is regarding left atrial enlargement, where we have two criteria, amplitude and duration, but we don't rely on an axis deviation. There is no axis deviation on left atrial enlargement. Another name, P Atrial, like cases of mitral stenosis. Mumtaz. We have now finished enlargement of the atrium. Easy? Now, let's go and finish the video with hypertrophy of the ventricle, the right ventricle and the left ventricle. As you know, the left ventricle is much more stronger than the right ventricle. So there will be more depolarization in this area than the right one. Okay? Now, here I made a comparison. The criteria of the criteria for right ventricular hypertrophy and the criteria for left ventricular hypertrophy. Regarding right ventricular hypertrophy, you're going to have two criteria. Number one, right axis deviation. As you start to notice, some of the signs, they're not specific. They're sensitive, but they're not specific. And that's why you need a combination of signs to diagnose such a case. So in right ventricular hypertrophy, you can see right axis deviation, kissing one another. Additionally, there might be disrupted R wave progression. So you remember what we said about the V1s and the V2, how the R wave, it gets bigger with each precordial leg? Well, in right ventricular hypertrophy, this is disrupted. In right ventricular hypertrophy, if it's bigger, now that it's bigger, that means two things. That means the vector will be deviated towards the right, and number two, the V1 will now record the much stronger right ventricle's depolarization as compared to the left side. So now, in case of right ventricular hypertrophy, the R wave will be greater than the S wave in V1, while the S wave will be greater in amplitude than the R wave in V6. So this is the normal. Well, in right ventricular hypertrophy, it is the opposite. This will be V1 and this will be V6. Mumtaz. This is a criteria to assess just by looking by your eyes that this might be right ventricular hypertrophy. Mumtaz. This is for right ventricular hypertrophy. Now let's look at left ventricular hypertrophy. In left ventricular hypertrophy, you might have a left axis deviation, right? But it's not to be reliable. Yani this finding might not be reliable for left ventricular hypertrophy as compared to right ventricular hypertrophy regarding axis deviation, because the left ventricle is already dominant for a reason. So it's a sign. It is another sign, but it's not as helpful. But regardless, to keep it simple, left axis deviation is another sign of left ventricular hypertrophy. Additionally, there are many other signs to add as a criteria for left ventricular hypertrophy. If any of you look for criteria of left ventricular hypertrophy, you will notice there is a criteria that is as big as this. There's so many criteria. The more you have, the better. But I will stick to one. I'll stick to one, or let's say two criteria additional to left axis deviation that is the most accurate, that is the most specific. And that is, I will take the R wave. Let's say I measure the R wave of AVL. Let's say this is AVL. I measure the R wave of AVL in amplitude. So I count the number of small squares, 1, 2, 3, 4, and I see whether it's 11 millimeter or not. If it's 11 millimeter, this is a good sign, left ventricular hypertrophy. Or I have another criteria. I could count the number, I could count the amplitude of the R wave of AVL regardless, and I add it. I add it along with the S wave of V3. So let's say this is V3. What do I mean? I mean I will count the amplitude of R wave of AVL. So let's say, for example, this is 7 millimeter. This is 7 millimeter. When I count the amplitude of R wave of AVL, I will do 7 millimeter plus whatever millimeter is in the S wave of V3. So let's say when I count the amplitude of S wave here, it said for me 3 millimeter. So 7 millimeter plus 3 millimeter equals what? 11 millimeter, or no, 10 millimeter. Is this abnormal? No, because as long as it doesn't exceed, or as long as it doesn't reach 20 millimeter total in women or 28 millimeter in men, as long as it doesn't reach this threshold, this is normal. So one criteria is I take the R wave amplitude, I add it with the S wave amplitude in V3, and I see whether it's 20 millimeter. If it's 20 millimeter total in women, left ventricular hypertrophy. 28 millimeter in men, left ventricular hypertrophy. I can use this criteria, or I can use additional criteria لحاله. R wave of AVL لحاله لو لقيتها 11 millimeter خلاص. This might be another good sign. ممتاز? Along with left axis deviation. Like I said before, the criteria for left ventricular hypertrophy is much more than this. In some cases, you also check whether V6, the R wave, is greater than the R wave in V5. In some cases, you do the same equation, but this time you add the R wave in V6 and you plus it with the S wave in V1. And you see whether it exceeds 35 millimeter total. So there's many other criteria. But in general, as a rule, to diagnose for left ventricular hypertrophy, once you exclude other causes, you look at criteria. The more you have, you're more likely the diagnosis. ممتاز. The rest of the criteria as simple as possible for left ventricular hypertrophy. Left axis deviation, then you add the R wave and the S wave, or you just look at the R wave of AVL لحاله. ممتاز. And as for right ventricular hypertrophy with right axis deviation, and you look at the disrupted R wave progression. The R wave progression has been affected in right ventricular hypertrophy. Now, one more criteria that is universal, necessary, that must be seen in whichever ventricular hypertrophy, whether the right side or the left side, one more criteria you must assess and confirm that it is there to confirm hypertrophy, secondary repolarization abnormality. What does that even mean? What does secondary repolarization abnormality? What is this criteria that will confirm whether or not you may have for sure hypertrophy of the right ventricle or hypertrophy of the left ventricle? ببساطة شديدة, basically, let's assume we have right ventricular hypertrophy, alright? So when we say there's secondary repolarization abnormality, that means addition to all of these findings, you will have this abnormality in repolarization. That means in this drawing, it will look like this. So let's say a patient has aortic stenosis. So the left ventricle will contract very hard towards an aortic valve that is stenotic. So the R wave will be very big. There will be a lot of electricity to pump this ventricle, which will obviously be hypertrophied in response to a stenotic valve. So let's say we have an aortic stenosis. That looks like this. P wave, Q, large R wave, then an S wave, then a T wave, right? Let's look at this. Like you see right here, we have a very ridiculously tall R wave in, let's say, leg 2. Secondary to aortic stenosis. This suggests there is more ventricular depolarization. There's more amplitude. That means the left ventricle is contracting even harder. It is being hypertrophied even harder. So there's a very large R wave. And the problem with cases such as aortic stenosis is that eventually this can progress to left-sided heart failure, right? And eventually, you might see a change here with prolonged left ventricular hypertrophy, seen in almost all cases. And that is, the ST segment, it will be depressing. The T wave will be inverted. How does it look like? Very simply. Mumtaz, very simply. This is how it will look like. So, we have a Q wave, an R wave, an S wave, and then we have right here a T wave inversion. Let me draw it one more time. We have here a T wave inversion. Now, what happened here? Well, what happened here is that there was secondary repolarization abnormality from the name. You have an abnormality in repolarization, which is secondary to ventricular hypertrophy. Is this a specific sign? No. But this is important because this will evidently confirm for you hypertrophy is there or not once you exclude other causes. Mumtaz. So here we have a tall R wave. Let's say this is AVL. Mumtaz. Let's say I found left axis deviation. Let's say the R wave exceeds 11 millimeter of the R wave. And now let us say that we can see secondary repolarization abnormality. That means ST segment depression, where you can see a gradual downslope, followed by a rapid, sudden upslope. Mumtaz. And then once you go beyond this ST segment depression, there will be what? There will be a T wave inversion. Mumtaz. There will be a T wave inversion, which suggests ischemia. So you have a downslope ST segment depression, a gradual downslope, then a rapid upslope, and then you have a T wave inversion. And in such a case, it is asymmetrical. You have an asymmetrical T wave inversion. What does it mean? Now it's asymmetrical. It's not even clear, right? Let me be more specific. It looks like this. Asymmetrical. And the ST segment that's being depressed is not being symmetrical with the T wave, which is seen in cases of STEMI. And we'll come to that in future videos. So here we have a case of secondary repolarization abnormalities. where we have an ST segment depression with an asymmetric T wave inversion. ممتاز. If you see this with a long R wave, for example in AVL exceeding 11 millimeter, you can diagnose this as left ventricular hypertrophy secondary to aortic stenosis confirmed in echo. ممتاز. So that's the idea between secondary repolarization abnormality. It is a repolarization abnormality secondary to left ventricular hypertrophy. And we will see this in other causes. Bundle branch block, for example. ممتاز. ممتاز. And it's the same. You'll see this in left ventricular hypertrophy as well as right ventricular hypertrophy, which is the secondary repolarization abnormality. ممتاز. So that's the final key criteria. This is not optional. This is necessary to confirm hypertrophy ولا لا. ممتاز. ممتاز. So all in all, this is the reason we have this case, this criteria, because of the hypertrophy. It caused abnormality on the repolarization. The repolarization is affected. And now we have officially finished the first abnormality. You may now check, look up any EKG. You may now check for any hypertrophy and especially any enlargement regarding the atrium, which is step number 7. And this is the one that we started with. ممتاز. For the next upcoming videos, we will be systematic. We would like to start with this one because it will implement what we've learned in the previous 2 videos. So, just to show you before we finish, I want you to look at the precordial leads. Take a look at them. Notice the precordial leads. Notice the R wave. Notice how it gets bigger, and it goes through a transition zone where it becomes biphasic in V3 or in V4. And then eventually, with each lead, it becomes bigger, the R wave. Din, 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 din. ممتاز. So this is what we're looking at. And of course, as you remember, the first upward deflection after a P wave will always be considered as, R wave. So this is clearly an R wave. ممتاز. And the second and the negative deflection after this R wave will always be, S wave. Never a Q wave. ممتاز. So this is what it looks like. ممتاز. And now we finish with our video.